we know that in the previously untreated patient, a vascular endothelial growth factor receptor tyrosine-kinase inhibitor is primarily the treatment of choice. There's a small number of patients that receive high-dose IL-2. There's a small number of patients that receive temsirolimus because of poor prognosis, but the most often used drug is a TKI. And the sequencing of agents, as I've reported at ASCO GU in 2013, suggests to me that the patient helps to define the sensitivity to a pathway inhibitor, so that after you've exhausted frontline treatment and are presented with the opportunity of either using an mTOR inhibitor like everolimus or another TKI like axitinib, both of which have high levels of evidence in the second-line setting, you use that approach based upon your response to prior therapy. And I'm sure that not everybody completely agrees with this, but in my practice, if a person has had an outstanding response to a prior TKI, I tend to keep them on a VEGF TKI in the second-line setting. If, on the other hand, the response has been modest, there's the appearance of new disease, there's rapid progression, I often think about using an mTOR inhibitor in that setting. So I somewhat tailor the second-line treatment to the first-line response, and I do the same thing for third-line treatments because many people exhaust most of the commercially available agents in the absence of clinical trial opportunities.